نفتتح إن شاء الله اليوم الثاني من Hepatology of the Nile 8. We are pleased to welcome you at the postgraduate course of Hepatology on the Nile 8, Advances in Liver and Gastrointestinal Disease 2022 World Expert Review at Semiramis Intercontinental, Cairo on March 17 to 18, 2022. We managed to bring together an eminent panel of 15 international experts from 11 countries who are dedicated to promoting the scientific advances in hepatology, gastroenterology, and endoscopy. Each speaker is a world authority in her field. We are confident that the program of Hepatology on the Nile 8 is an attractive program and will enhance the education of hepatoenterologists, gastroenterologists, and endoscopists in the care and treatment of patients with liver disease and gastrointestinal disease. Hepatology on the Nile 8 has been granted 12.5 credit hours from the American Association of Continuing Medical Education, AACME. We hope that this course will engage attendees in the excitement and astonishing growth in the field of hepatology and gastroenterology and prepare them to meet the growing challenges of caring of patients with liver and gastrointestinal diseases. Finally, we would like to extend a hearty welcome to our foreign guests and with them a wonderful and memorable stay in Egypt.
Bismillahirrahmanirrahim. I would like to welcome Professor Imam Waqid, professor from National Liver Institute. He is going to talk about National Surveillance Program for Hepatocellular Carcinoma. You are welcome, sir.
Assalamu alaikum. I would first like to thank the organizers for inviting me. And I'm going to talk very briefly on hepatocellular carcinoma in Egypt. And the rest of the talk will be given by Dr. Muhammad Abdullah, who is the manager of the National HCC program in the National Committee for Control of Viral Hepatitis. So it will be a split talk, and I will first discuss hepatocellular carcinoma in Egypt. Hepatocellular carcinoma has been increasing globally. 30 years ago, there were 500,000 cases of HCC. Last year, almost 1 million, so it's on the increase globally. However, in Egypt, it's increasing even more. This is coinciding with the aging of the hepatitis C infected patients, and they're getting closer to the hazard line of developing liver failure and HCC. This is the estimated age standardized rate of HCC in Egypt from 1987 till 2020. It has increased more than 15 times, from 2.4 or 2.5 per 100,000 to almost 35 per 100,000. And we hope that our national treatment program for hepatitis C that was in 2018 and 2019, and after curing almost everybody with hepatitis C, that this rate will increase soon in the future. This map from 2002 shows the global prevalence of HCC. Egypt was a middle prevalence country with an ASR of 8.2 per 100,000. And this is the recent map from GloboCan, and Egypt now is one of the highest countries with HCC prevalence. HCC has decreased in West Africa and Sub-Saharan Africa and in East Asia because of the vaccination of hepatitis B. However, in Egypt and in Mongolia, due to hepatitis C, it has not decreased yet. And this is the country ranking of HCC. Mongolia is the #1 country in the world, and unfortunately now Egypt is the #2 country in the world. In Egypt, liver cancer is the #1 cancer, higher than breast cancer, and even higher than bladder cancer, which was the #1 cancer in males maybe 20 years ago. And this flow chart shows the staging and treatments given for HCC. And in Egypt, only 30% or less present in curable stages, and most patients present in stage C and D, which are only for systemic or palliative treatment, while in a country like Japan, more than 60% of the patients present early in a curable stage, and less than 10% only present in end stage or advanced stage. We analyzed data from our hospital for the past 5 years, almost 15,000 new cases of HCC, and these were the treatments offered. Only 20% of the cases present early, and most cases present late. So there is a need for surveillance for HCC in Egypt. Is surveillance possible? We had a study in our institute 10 years ago, and we showed that compliance with surveillance was average. Patients came back for screening and rescreening, and screening was very effective and cost effective. This is the staging of patients with HCC discovered on screening compared to patients who presented out of screening. Almost all patients were stage A compared to less than 25% of the patients. Tumors were smaller. Portal vein thrombosis was, and extrahepatic spread was almost non-existent on screening. And it was cost effective to screen with both ultrasound and I'm sorry, and alpha-fetoprotein. So the Egyptian Society for Liver Cancer adopted the screening program using ultrasound and alpha-fetoprotein. And unfortunately, since the guidelines came out in 2011, we did not have a national program for screening. Until 2019, we started a national program for screening. And this year, or late last year, we started a national program for systemic therapy on the expense of the state, so that patients who need therapy will get it for free. The national screening program is a very important program, and the best one to talk about it would be Dr. Muhammad Abdallah, who is a professor in the National Research Center, and he is the manager of the HCC program in the National Committee. So he will take over and present our data.
Thank you, dear Professor Imam Waked. It's my pleasure to be here with you, dear professors, in this conference. I'll make an overview about the Egyptian HCC surveillance program. As Professor Imam said, we started this program at September 2019. It was following the national campaign of campaign for hepatitis C. As you know, we faced a lot of patients with liver cirrhosis that needs follow-up even after achieving SVR, and so we started our program. This program is offering a visit every 4 months for each patient with liver cirrhosis to make for early detection of HCC containing alpha-fetoprotein and ultrasound. We include all patients with liver cirrhosis, whatever the etiology, and suspected cases are referred for specialized center for dynamic imaging studies and treatment if needed. Our matrix of the program contains 75 surveillance center and 36 referral center for CT, 63, and MRI, we have 30 centers for referral centers and a 20 MDT clinic for referral. These numbers are keeping increasing with the increasing with the progression of the program. We include all patients of liver cirrhosis regardless of the etiology. We have to be proven by liver biopsy, transit elastography, and we don't rely on ultrasound for inclusion of patients. We make a database for storage of the data of the patients and to unify the way of methods of data collection. It started first with a VPN closed networking, and then it was shifted to a cloud server database. This is screenshots from the system we are using. Each patient, we can make a patient query using ID and the patient data keeping up, and we make a referral with an electronic generated forms using the database to make a patient activity log for the patient to know the progression of the cases all over his treatment course or follow-up course. This is a program cascade till now. We are now in March 2022. Of course, we have some delay in patient inclusion due to pandemic of COVID-19, but we keep the program running in the pandemic with the precautions done to face the pandemic. We have now more than 100,000 patients recruited, 88,000 patients done their first assessment visit with ultrasound and MRI, ultrasound and alpha-fetoprotein. 3,000 of them referred for suspicion of hepatic focal lesion, and 923 patients has been proven to be an HCC. So we are talking about 24% of patients referred for dynamic imaging has been proven to be an HCC, and it's 1.1% prevalence among the cirrhotics in the studied group. 726 patients are referred to treatment, and others whose the decision is a best supportive care in 22%. As we are keeping on visits, we are facing that the program aids us to discover cases in an earlier phases, smaller focal lesion as we move on with the program, and this will make a good future in the path of elimination of viral hepatitis and the morbidity and HCC-related mortality. Then in 2021, we starting our program for systemic therapy for HCC. The program now contains sorafenib and regorafenib as the first and second line choices. It started in 20th of January 2022 in 22 NCCVH treatment centers. We make a protocol for using systemic therapy and launch it in January 22. This distribution of our treatment centers across Egypt, and the second phase of treatment center is under preparation. The program offers treatment on the basis on the state, and also it provides care kits, follow-up investigations for free. Till now, we have 423 patients started therapy, and thank you.
Thank you, Professor Muhammad, for this elegant talk. Next, we will shift to Professor Dr. Gamal Ismat, Professor of Internal Medicine, Cairo University, Egypt. Prediction of HCC after achieving SVR following direct-acting antiviral drugs. Online, yes. دكتور جمال، نفتح المايك لو سمحت.
بسم الله الرحمن الرحيم. I hope that you can hear my voice and see the slides.
Yes, we hear you, Professor Gamal. Okay.
Thank you very much for the organizing committee for inviting me to this important workshop. And postgraduate, I will talk today about the long-term follow-up after HCV treatment by direct antiviral agents, especially the hepatocellular carcinoma dilemma. All of us know that we started the direct antiviral agents about 5 years ago, and these direct antiviral agents give us a good response. Up to the extent that most of the patients are now treated by direct antiviral agents. What are the follow-up after treatment by the direct antiviral agents for our patients? We started the direct antiviral agents on the baseline. At the end of treatment, there is amelioration of the inflammation. After sustained virological response, there is regression of fibrosis and maybe resolution of some fibrosis and improvement of liver functions. And when we go forward, we have improvement on cognitive dysfunction and improvement on portal hypertension and improvement on prognosis. What about the relapse? In fact, after sustained virological response, the possibility of relapse is very low. In this study, we can see that the relapse is only 1 per 1,000. Maybe there is a reinfection about 2 per 1,000 by the same genotype, and also reinfection by 1 to 1,000 from other genotype. So we are not facing a problem for the relapse after sustained virological response. But the problem mainly on the impact of treating chronic HCV infection by direct antiviral agents on the risk of hepatocellular carcinoma, whether the incidence of new cases or the recurrence after treatment of patients who has HCC before. In this study and many review, our group published this data, and you can notice that the incidence of hepatocellular carcinoma, there is a conflict between the results. Some results say the incidence is only 1%, and it is about 7% in other studies. Even also in the recurrence of hepatocellular carcinoma, after treatment of this hepatocellular carcinoma and treatment of HCV by direct antiviral agents, there is also debate and there is also conflict results between 5% to about 50%. So there is still debate about the development of hepatocellular carcinoma after using direct antiviral agents. So it is now evident that eradication of HCV by antiviral treatment reduces but doesn't eliminate the risk of hepatocellular carcinoma, especially in patients with advanced fibrosis F3 or cirrhosis F4. And there is a universal agreement that these patients with advanced fibrosis or cirrhosis needs to continue HCC surveillance. To explain why there is a conflict of the results, this study, which was published in Journal of Hepatology in 2021, say that HCV treatment for patients with advanced fibrosis or cirrhosis, we have 2 arms. One arm, there is a reduce in hepatocellular carcinoma risk, and this is because there is regression and resolution of fibrosis after direct antiviral agents, and also no new related genetic or epigenetic pre-neoplastic changes. So the risk in this group of patients is very low. But unfortunately, we have another group of patients where there is fibrosis, persistence, or progression, maybe from other causes like alcohol, NASH, and those who are in older age group, and also persistence of genetic and pre-genetic pre-neoplastic changes in these patients, the hepatocellular carcinoma risk persists. And this is a very important study. They are following patients after treatment for HCV for more than 10 years. And when we are talking about 10 years, of course, there is a patients who received interferon, pegylated interferon before, and they are following them after receiving pegylated interferon. And there is another group of patients who received direct antiviral agents. Let us concentrate on these patients who received pegylated interferon, and we have for them a long-term follow-up for more than 10 years. If you look to this, for those patients who received interferon and their FIB4 was high, more than 3.25, you can see this is the curve for these patients. So the risk of development of hepatocellular carcinoma is present even in patients who have sustained virological response by using pegylated interferon and following them for 10 years. But if the patients have a low FIB4, less than 3.25, and he received interferon, you can notice that there is decrease on the development of hepatocellular carcinoma, and maybe after some time after development of established cirrhosis, they started to have another risk. This is as regards the patients who received interferon. What about the patients who received direct antiviral agents? The same. If the patient have a high FIB4, more than 3.25, the risk is present, but it decreases after 3 years. And if he has a low FIB4, the risk is low. So they proposed that if you have a patient with cirrhosis and the FIB4 is high before and even after the treatment, the incidence is high up to 5%. But if the patient is cirrhotic and he has pre-treatment low FIB4 and post-treatment low FIB4, the incidence is low. This is in cirrhotic and even in non-cirrhotic. So this is a very important study which was published in 2019, and it answered the question if there is a difference between using interferon and direct antiviral agents. No, there is no difference, but the difference in the cohort itself. If you are using the interferon in a cohort with high FIB4, you will face also the same problem of the risk of development of hepatocellular carcinoma. Let me go for another study which is coming from Germany. In this study, they are following about 10,000 patients for about 7 years after they receive the direct antiviral agents. 1/3 of these patients having liver cirrhosis at baseline, and during the time of follow-up, 2% of the patients died, and there's a liver-related clinical events in about 5.7 of these patients. This liver-related clinical events is liver transplantation, development of hepatocellular carcinoma, development of hepatic decompensation, or increase in the MELD score. When they go in more depth for patients who developed hepatocellular carcinoma, they found that if the patient is cirrhotic, the annual risk of hepatocellular carcinoma is 1.2 in the first 2 years, and it decreased to less than 1% from 3 to 7 years. So the incidence is low. It's not high like we proposed in the other study. And also, they look for what are the risk factors for development of hepatocellular carcinoma. It is liver cirrhosis and treatment experience before. So this is the German study. We have here in Egypt another study which is in press looking to 28,000 cirrhotic patients. So we are talking about big number of patients with cirrhosis who received direct antiviral agents, and we have follow-up for about 127 weeks. And we are looking for the patients who developed hepatocellular carcinoma, and we apply the same principles of the FIB4. And we can notice here that the main problem is that on the patients who have a high FIB4 before starting treatment, and still the FIB4 is high even after receiving the direct antiviral agents. And the incidence for these patients, the annual incidence is 2.5 for these patients. So it is clear for us that you cannot talk about all the patients on the same way. If you have a patient with low FIB4 before and after treatment, the FIB4 is still low, the incidence is less than 1%. So we have to go for what we called a personalized medicine. We have a difference between patients and patients. Shall we screen all the patients by the same technique, or we can depend on these scores for choosing patients who needs more surveillance and needs more screening for detection of hepatocellular carcinoma? Another study is coming also from Egypt, from Dr. Gamal Sheikha group, and they are also looking for a score system to look for those patients who may develop hepatocellular carcinoma more than the other cirrhotic. And they proposed this score depending on the sex of the patients, the age, the fibrosis stage, the albumin, the alpha-fetoprotein, and they said that by this score they can put patients on low risk, intermediate risk, and high risk. And those patients with low risk, the development of hepatocellular carcinoma is about 1.6. Intermediate risk, it's about 4.5. And high risk, it's about 7.6. So it is clear for us that we can have data to categorize patients on those with low risk, intermediate risk, or high risk by a score on another. There is also a score which was published this year, 2022, and this score also coming from the United States, and they depend on the age, the sex, the platelet count, the gamma GT, the bilirubin, the alpha-fetoprotein, and also they put patients into groups of low risk, intermediate risk, and high risk. But for the first time, there was a publication in this study saying that early hepatocellular carcinoma detection using magnetic resonance is cost effective in high risk patients with cirrhosis. So we are now going to more and more details on the patients who have cirrhosis. Not all of them are the same. If you have patients with high risk of development of hepatocellular carcinoma, maybe it is not wise enough to depend only on ultrasound and alpha-fetoprotein. Maybe you can depend on magnetic resonance, triphasic CT, or on other lab investigation like Galad score or something like that. And here, this is the study saying that even the magnetic resonance for these patients with high risk can be cost effective. As Dr. Imam Waqid and Dr. Muhammad Abdullah talked about our national program for HCV surveillance, which started on September 2019, we still depend on ultrasound and examination and alpha fetoprotein, I think that we have to start for a special group to look for the other methods for surveillance to detect the patients with high risk. So it is very clear for us that direct antiviral agents for HCV management is very important because it prevents patients from developing cirrhosis. And if you prevent cirrhosis, you are also preventing hepatocellular carcinoma. It prevents transmission from this patient to healthy individual. It decreases the risk of cryoglobulinemia vasculitis, the non-Hodgkin lymphoma. It decreases the acute coronary syndrome, the cardiovascular diseases, the insulin resistance, and improve atherosclerosis, and improve quality of life and chronic fatigue syndrome and survival. But the most important thing is to start the treatment for patients with HCV as early as possible, because this will prevent him from developing of cirrhosis and going on to the dilemma of hepatocellular carcinoma. In summary, hepatocellular carcinoma possesses a serious problem in Egypt, and cirrhosis, viral hepatitis, male sex, and older age are the main factors for that. Of course, metabolic syndrome and NASH, and I am looking to hear from our good friend about the NASH and hepatocellular carcinoma, and also hepatocellular carcinoma surveillance for early detection and reduction of hepatocellular carcinoma-related mortality is a major pillar, especially in a high-risk group, and HCC multidisciplinary team for treatment center are the key for management of success. And I am looking to hear also our friend Peter Galli talking about NASH and hepatocellular carcinoma. And thank you all, and I am inviting you to attend the United Conference of Hepatology and Infectious Disease on 22 of September this year. Thank you very much.
Thank you very much, our Prof. Dr. Gamal Ismat. I hope that you solve the problem whether direct acting antiviral increasing or decreasing, or what it did with the development of hepatocellular carcinoma. I want to thank our Prof. Dr. Imam Waked. If we talking about hepatology on the Nile, we must mention that our dear Prof is the founder of Hepatology on the Nile. Thank you for your coming, and thank you for this elegant presentation. Thank you, Dr. Muhammad Abdullah, for your elegant presentation. Thank you for all the effort you did for the treatment of hepatitis C and the treatment of hepatocellular carcinoma in Egypt. Now we are going to hear our Prof. Dr. Ashraf Omar.
It's my pleasure and honor to present dear Professor Peter Galli, Professor of
Dear Professor Nabil Loma, dear friends and colleagues from Egypt, thank you very much for the kind invitation to present at the postgraduate course in the setting of Hepatology on the Nile 2022. I would have loved to come to Cairo in person, maybe next year, see how the pandemic is developing. These are my disclosures. My topic today is the contribution of fatty liver to hepatocellular carcinoma. I'd like to highlight at the beginning that we do have a significant contribution of gastrointestinal disease in general to morbidity and mortality, highlighted here for cirrhosis of the liver and liver cancer. reducing life expectancy, and liver cancer is doing this actually more relevantly than stomach cancer. And the topic of today, linking fatty liver disease to this cancer, is supported by the observation demonstrated here, where it is clear that there is a large proportion of hepatocellular carcinomas which can be attributed to NAFLD. This is particularly the case for India or UK, but also in Germany there is a high risk to develop hepatocellular carcinoma in the setting of fatty liver disease, and the proportion can be as high as 40% of the patients with HCC stemming from fatty liver. And adding to the complexity, it's not just the cirrhotic patient who is developing a tumor. It can be fatty liver without cirrhosis, even without fibrosis, resulting in the interesting question when to start screening and whom to screen. We see over the last 2 decades a continuous increase in compensated cirrhosis and chronic liver failure attributed to NASH, and there are models predicting that there will be a continuous increase in the next years and decades. An increase in the total cases of fatty liver, of NASH patients, of incident cirrhosis, and more importantly, incident liver-related death, and also hepatocellular carcinoma. Where we already see this impact is in the liver transplantation setting. Patients with NASH are, both for males and also for females, increasingly providing NASH as the underlying etiology for liver disease resulting in transplantation, and this is in sharp contrast to the observation with respect to HCV-driven hepatocellular carcinoma, which is on the decline. In certain populations, HCC, as a result of NASH, is already the leading cause of cancer-related death. This is the case particularly here in Mexican American, where the rank is #1 for cause of cancer death rank. What do we offer these patients at risk? So whom can we give a better chance of survival, better outcome, better prognosis if we do surveillance? It is relatively well described, although technically not an easy task, that surveillance in patients with liver disease is resulting in an earlier diagnosis in terms of curatively treatable hepatocellular carcinoma. So if you do surveillance, curative setting is more common than palliative setting. And conversely, if you don't do surveillance, the likelihood that the patient is diagnosed at a late stage is very high. And those patients who are undergoing surveillance do have a better outcome compared to those not undergoing surveillance. So surveillance is playing a role. However, we need to be aware that overall surveillance is actually rather neglected, and an observation is stemming from the non-interventional Gideon trial, where overall the proportion of patients in BCLC stage A, so early stage disease, was only 20%, 1/5 of the total population, and this is quite poor considering that patients with a risk of HCC have an underlying liver disease which can be diagnosed. That you can do better is actually the case in Japan, where a much higher proportion of our patients with HCC are diagnosed at an early stage. However, in the end, it's an complex and difficult question which we cannot precisely answer. I will come at the come back to this at the end of my talk, where we actually start with our screening strategies. In general population would be too many, even naval patients are too many. NASH patients are still too many. Patients with NASH and cirrhosis, well, here it's getting in a range where it's probably doable. I'll come to this. Let's take an interim analysis of the pathophysiology of the disease. There's this continuum, fatty liver resulting in inflamed fatty liver, fibrosis, cirrhosis, and HCC. And I already mentioned the problem that even at earlier stages without cirrhosis, fibrosis, HCC may develop. We have modifiers of the disease, which are inherent genetic modifiers or which are the result of sedentary lifestyle, obesity, diabetes. And age and sex also are attributors to prognosis and the risk of developing cirrhosis and hepatocellular carcinoma. What's very clear is that diabetes mellitus type 2 is resulting in a much higher risk for cirrhosis or for hepatocellular carcinoma if there is the presence of NASH. So that is a major contributor, and in a situation with liver cirrhosis, diabetes must be assessed. There are genetic modifiers of the disease, and the most prominent one is PNPLA3 or adiponutrin. It's not precisely understood what PNPLA3 is doing, but it is having an impact on the remodeling of lipid droplets. And if there is a SNP, a polymorphism contributing to the disease, we have an accumulation of lipid droplets in hepatocytes. Another modifier, genetic modifier, is transmembrane 6 superfamily 2, which is also with certain SNPs clearly contributing to the risk of HCC development. It is again associated with lipid metabolism. What is observed is what we call lipotoxicity, an overloaded hepatocyte with lipid in the cytoplasm, resulting in an inflammatory situation and pro-inflammatory, pro-fibrogenic extracellular vesicles and mediators contribute to pathogenicity, and in the future actually might also be used for the diagnosis of patients at high risk. The lipid overloaded hepatocyte dies by various means and the cellular content, but very interestingly, membrane blebs, which are shedded into the perfusion for the long-term run and in the future might be very interesting biomarkers for patients at risk. We know that the nutritional content but also the microbiome of the gut is contributing to pathogenesis of the disease. It is complex. For example, if you take polyunsaturated fatty acids, they can be protective, but they can also result in a more severe form of liver damage. Very well described is the role of the microbiome. We can separate a healthy microbiome from a dysbiosis, and the dysbiosis, in particularly in conjunction with a leaky gut, is contributing to the damage of the liver, for example, by lipopolysaccharides, in the end resulting in fibrosis and cirrhosis and liver cancer. There are simple experiments in mouse models where, for example, with nitrosamine and carbon tetrachloride, tumors are produced, and it has nicely been demonstrated that if there is mutated toll-like receptor 4, which is sensing bacterial signals from the gut, if this is mutated, no tumors develop. And as another, if you want simple form experiment, if you perform gut sterilization by using antibiotics, also reducing the development of tumors. So a clear contribution of bacteria to tumor development. Unfortunately, we do not have a somatic genetic profile, a precise hepatocarcinogenic signature, which would be describing in full the role of fatty liver disease. It's rather general hepatocarcinogenic mechanism. We know that NF-kappa B family of transcription factors plays a role. The signaling cascade of PI3-ACP10 is playing a role. And then certain factors have been described, and I'm highlighting a few. We, for example, work with BCL3 in a hepatocytic overexpressing BCLC mouse. We do see fatty liver accumulation and inflammation. IL-17A has been described well as a result of lipotoxicity and contributing to NASH and HCC development. And what is very relevant in a recent discussion is the role of T-cell infiltrate, and in particular the CD8 T-cell contribution. This is coming from the Heichenwälder group. It has been observed that there is an accumulation of CD8 cells as a result of NASH. This can be further accumulated by addition of high-fat diet, and interestingly also by anti-PD-1 ligand monoclonal antibodies. This results in a high rate of CD8 T cells and in a high rate of tumors. And this tumor development is apparently driven by CD8 cells, because if you antagonize CD8, then you reduce the tumor load. So there is an accumulation of CD8 PD-1 positive cells contributing to hepatocarcinogenesis. And in those models, if there are tumors and you try what we are doing in humans to treat with PD-1 ligand inhibition, it is not working in this context of fatty liver. In conjunction with the clinical observation that in some trials, the non-viral patients with hepatocellular carcinoma, which to some extent are NASH or NAFLD patients, are responding less well to immune therapy, and that has also been demonstrated in some cohorts that patients treated with PD-1 antibodies are doing less well if there is a background of NASH compared to a non-NASH background. In that situation, it has been claimed that immune therapy is not working. If we take a look at the newer trials, such as the Himalaya trials, it's actually not that clear, because in Himalaya, tremelimumab and durvalumab treated patients, the situation is characterized by a good response in NAFLD patients. So that's an open question and will be interesting in the future to look at. We have clinical means. We know that the metabolic syndrome, diabetes, high blood pressure is contributing to NASH and cirrhosis development and hepatocellular carcinoma. Type 2 diabetes results in NASH and in advanced fibrosis, so that is relevant. Hypertension results in higher fibrosis, or is correlated with higher rate of fibrosis, and with cardiovascular disease, and the inflamed liver is probably contributing to arteriosclerosis and plaque development. that can be nicely demonstrated by analysis of clinical data, and we have performed such an analysis from patients in the decade 2000 until 2010. And in our NASH subcohort, we could clearly demonstrate that obesity, high BMI, diabetes are associated with the risk of developing NASH-driven HCC. And in that setting, we have clear-cut clinical data supporting risk assessment. That is coming to a point where we ask the question whether we can establish models which estimate the risk of individual patients, because what I was pointing out in the beginning was we have such a high number of patients with fatty liver disease, we can't screen them all. So we would like to model the risk in high, medium, and low risk, and that can be done actually by relatively simple means. So if we take patients with alcoholic liver disease or non-alcoholic fatty liver disease, they have a genuine risk to develop hepatocellular carcinoma. And if we take the FIB-4 score, which is comprising age, platelet counts, and aminotransferases, then we can actually, by setting a threshold with patients, we can separate patients with a very high risk and a lower risk of developing hepatocellular carcinoma. If you take the FIB-4 score and add sex, diabetes, albumin to it, so more complex scoring, then you can even better titrate patients with high risk, medium risk, and low risk. And it will be seen in the future whether these models are in the clinic used to stratify patients according to their risk. In view of the difficulties to assess patients with high risk and the large numbers of patients with fatty liver disease in the past, there were basically no recommendation for screening. 10 years ago, it was claimed that the non-cirrhotic patients are just not having a risk high enough, incidence high enough that screening would be worthwhile. We felt the same when we coined the EASL clinical practice guideline in 2018 and were at least requesting that patients should have a significant proportion of fibrosis F3 in order to justify surveillance. In summary, dear friends and colleagues, diabetes, age, obesity, the presence of cirrhosis and genetic risk modifiers are contributing to the individual risk of a patient to develop hepatocellular carcinoma in a setting of NAFLD. In those patients currently, probably if they are cirrhotic and if they have a significant fibrosis detected in the past, we suggest that based on an individual assessment, we perform screening and do so by ultrasound. If feasible in a heavily obese patient, it might be a problem, plus minus AFP every 6 months. And in the future, we probably will have a better fine-tuned armamentarium to perform screening. In summary, Mr. Chairman, ladies and gentlemen, there are several risk loci predisposing NASH development and NASH progression to hepatocellular carcinoma, most prominently adiponutrin and TMF6SF2. None of these genetic modifiers and also none of the genetic alterations are precisely specific for NASH-driven hepatocellular carcinoma. There are no specific somatic mutations for NASH-driven HCC. It is a complex scenario where inflammation, immune cells, CD8 cells, and global metabolic changes are components of NASH HCC, which are driving carcinogenesis. We recommend to do screening in patients with NASH cirrhosis And if you take clinical parameters such as age, sex, BMI, diabetes, aminotransferases, albumin, and platelets, you may even have a better fine-tuning of patients at risk, conversely to patients at low risk. In the future, we will see risk modeling and stratifying by biomarkers. Thank you very much for your kind attention.
Thanks a lot, Professor Peter. Hoping to still with us until discussion. Next speaker is our professor, Professor Ashraf Omar, Professor of Tropical Medicine, Cairo University, updates in systemic therapy of HCC.
Bismillah ar-Rahman ar-Rahim. It's really my pleasure and honor to be with you in this outstanding conference, and I would like first to thank my inviting committee, Dr. Nagla, Dr. Nabil, and I would like to welcome our guest international speakers, Professor Peter Gallet, Professor Maria, and Professor Rafael. You are so much welcomed. Systemic therapy and what's new? Actually, when we go to the staging workup of hepatocellular carcinoma, we can see that depending on the performance status of the patients, the liver status, and the tumor burden, we have 5 different stages. Very early stage, single lesion or 3 lesions, less than 3 centimeters. The intermediate stage, multiple lesions with no vascular or extrahepatic, and advanced stage. And accordingly, we having a protocol for treatment. According to the BCLC, according to the general condition, liver status, and the tumor, we have 5 stages, and the systemic therapy is eligible for the advanced stage, and we've stayed for more than 12 years having just one only systemic therapy, which is the sorafenib. The updated guidelines of the BCLC 2022 is having much different options in the advanced stage. We have now first-line treatment, second-line treatment, and third-line treatment. Really, the systemic therapy has a substantial progress in the past 5 years from just single drug, which was the sorafenib, and we are now having much combined therapy with marked increase in the overall survival. And the combining therapy now is the trend. The immune checkpoint inhibitor with other molecules is become the trend and the standard of care of the treatment of hepatocellular carcinoma now. Now, the systemic therapy is not only in the advanced stage, however, it became now in the near future in the early stage and in the intermediate stage as well. You know that the early stage, the standard of care is the leukoregional treatment, surgery, or liver transplantation. And the intermediate stage is the standard of care is TACE. However, systemic therapy now is in the future may become the standard of care in the early stage and as an adjuvant, the intermediate stage with or without TACE, as we are going to see. Let's start the story of the systemic therapy, which has started in 2007 with the introduction of sorafenib by the SHARP trial, and we've stayed more than 10 years. They're becoming in the another molecule, which is the lenvatinib, as a non-inferior for the sorafenib as first-line treatment as well, and till 2020, the introduction of the first immune therapy as a first-line treatment of hepatocellular carcinoma. So by now, we have, as a first-line treatment, 3 molecules: sorafenib, lenvatinib, and the immune therapy. However, in the second line treatment, we have a lot of molecules: regorafenib, lenvatinib, and ramucirumab, starting from 2017, and also the introduction of some immune checkpoint inhibitor as second-line treatment. By now, the systemic therapy, according to the mode of action, we have two main modes of action: the tyrosine kinase inhibitors, the sorafenib, lenvatinib, regorafenib, cabozantinib, and ramucirumab, and the immune checkpoint inhibitor, which is the anti-PD-1, anti-PD-L1A, and anti-CTLA-1. According to the mode of action, as you know, that they are working, the tyrosine kinase inhibitor are working mainly in the endothelial cells, blocking some receptors, the VGL-R1 and 2, and also in the tumor cells, and as well as blocking another signaling pathways, important signaling pathways like RAS kinase pathway, which is important in the HCC evolution. Tyrosine kinase were in the guidelines. According to the clinical trials, they have put, after the finishing of the clinical trials, all these molecules have been put in the guidelines. The first line treatment was the sorafenib and lenvatinib, and the second line treatment, regorafenib, cabozantinib, and ramucirumab. Then you know the famous SHARP line since 2006 or 2007, and with a significant overall survival over the placebo, 10.7 versus 7.9, and it also has been achieved in the Asian-specific trial, 6.5 versus 4.2. And accordingly, it has been put as a first-line treatment for the hepatocellular carcinoma. Recently, the overall survival of sorafenib has been documented again with another along years with all clinical trials, grade 3 clinical trials. The SHARP, of course, has started with 10.7 overall survival. Then the REFLECT versus lenvatinib showed improved overall survival, 12.3. Then the CheckMate 459 versus the nivolumab, again improved overall survival, 14.7. And lastly, 13.2 in the EMBRAVE 150 versus the atezolizumab. So the overall survival of sorafenib has been increased over time and has been also more and more documented. One of the important factor of the overall survival, impact on the overall survival, not only the burden of the HCC, it is the liver status, and of course the overall survival in patients treated with sorafenib is much better in child A versus child B, and so on. And the most important again is the adverse effect. It is mild to moderate, not very severe, and the most common drug-related were fatigue, skin, and GI disorder, which is easily modulated. The most important is these data, according to the meta-analysis, more than 13 studies with univariate pooled HR of the sorafenib and the dermatological adverse effects showed that the dermatological effect of sorafenib is associated with better clinical outcome and may be used for clinical decision making. So when we are facing a significant dermatological effect in sorafenib treatment, it is one of the good prognostic factor of the treatment with sorafenib. Again, when we can modulate and adjust the dose of the sorafenib during the adverse effect, we are capable of having much better overall survival, much better increase the duration of therapy, and of course the survival will be much better. And again, the sorafenib showed a benefit in post-liver transplant recurrence of HCC as well. And the most important, the early initiation of sorafenib as a systemic therapy in patients which is ineligible for TACE, in patients with intermediate stage, showed a much better overall survival. When we have a longer overall survival, observe it in patients with early start of sorafenib treatment. The cohort 1 patients with early start of sorafenib versus the second cohort without early start, there is a significant overall survival in patients with early start, 16.2 versus 12.1 month. So sorafenib became first-line treatment with a mild adverse effect, and the trend toward longer overall survival over time with sorafenib. Comes next the lenvatinib, which is the second multikinase inhibitor, showed the mainly very close similarity with sorafenib, and sorafenib is also having a more additional mode of action, blocking the RAF-RAS kinase inhibitor, and lenvatinib is a non-inferior to sorafenib, showed an overall significant overall survival, and of course again with progression-free survival, significant progression-free survival over sorafenib. The most important is it's not better to start lenvatinib with a child B, because it showed an objective rate of overall survival, significant lower overall survival, and median progression-free survival versus the patients with child A. So the NCCE guidelines recommend lenvatinib only in child A cirrhosis. So lenvatinib became a first-line treatment as a non-inferior to sorafenib. Comes the second-line treatment. We have three molecules: the regorafenib, cabozantinib, and ramucirumab. They showed, and ramucirumab with patients having alpha-fetoprotein more than 400 nanogram per ml, and regorafenib for patients were tolerating to sorafenib. All these molecules show significant overall survival versus placebo after sorafenib failure. We come next to the second molecules, the second mode of action of the systemic therapy, which is the immune checkpoint inhibitor or the immune therapy. And as you know, we have three main mode of action: the anti-PD-1, programmed cell death 1, or programmed cell death 1 ligand 1, or anti-cytotoxic T lymphocyte A1. These, when we show the mode of action, the first engagement with the T cells of our immune system over the malignant cells, the first signaling pathway is with the T cells and the malignant cells. The second signaling pathway would be through immune co-regulatory signals, which could be inhibitory or stimulatory. The inhibitory were the PD-1, the PD-L1, and the anti-CTLA-1. So blocking these agents, the PD-1, PD-L1, and CTLA-4 may improve the clinical outcome by reversing the immune suppressive environment of the hepatocellular carcinoma by activating or reactivating the T cells against the malignant HCC cells to overcome the mechanism of the immune evasion. Where the immune therapy in the guidelines, we might use the immune checkpoints as a monotherapy. We have two clinical trials, Checkmate 459 and Keynote 240, Nivo and Pembro, and the combo treatment, the Atezo in Brave 150 and the Duratrim in Himalaya trials. We start with the Nivo Checkmate 459, and unfortunately, the predefined threshold of the statistical significance for the overall survival was not achieved, and versus the sorafenib, so it is not recommended in the guidelines as first-line treatment. And the Pembro, again, showed some significant overall survival and has been approved as a second-line treatment, accelerated approval for the second-line treatment. And these were monotherapy. We came to the combo therapy. Why combo therapy? Combo therapy, when we look to these data, the combo treatment versus the monotherapy, all combo treatment is having a higher overall survival and a higher progression-free survival over the monotherapy, and also the higher objective response, OR, versus the combo versus mono. So the rationale of the combo is to combine two different molecules and changing the cold tumor to a hot tumor that can be easily attacked by the immune checkpoints and destroy the malignant cells. So the beauty of the combination therapy is to turn over the cold tumor to a hot tumor, enabling the immune checkpoint inhibitor to have checkpoint inhibitor to have greater effect, providing a unique synergistic effect, so higher percentage of cancer cells will lose the capacity to hide from the immune system. Here is the combo treatment. First, the IMBRAVE, the atezolizumab versus sorafenib, with a 34% reduction of the risk of death. Overall survival was 19.2 versus 13.4 in sorafenib. Also 35% reduction of the risk of disease progression or death. The progression-free survival is 6.9 versus 4.3. And again, the time to deterioration is much better in the atezolizumab over sorafenib, 11.2 versus 3.9. Another combination, the nivo-ipi, with a significant overall survival in the arm A, with 22.4 overall survival over the other different arms. And nivo-ipi received accelerated FDA approval for HCC after prior sorafenib based on the outcome from the checkmate. And came to the Himalaya trial, which is recently introduced 2-3 months ago, the trimi plus dura versus durva versus sorafenib. There is a significant overall survival in the combined therapy over sorafenib, 16.4 versus 13.8. Again, the progression-free survival is significantly higher in the combined therapy over sorafenib, and also the durva as a monotherapy is having a much better overall survival, 16.6 over sorafenib, 13.8. So the future now for the systemic therapy is the combo therapy. Immune checkpoint with other modalities, with resection, with TACE, with multikinase inhibitor, even with cytotoxic agents. And here is the future upcoming clinical trials, immune checkpoint inhibitor with targeted therapy to induce inhibition, much more inhibition, much more synergy, to immune checkpoint inhibitor or immune checkpoint inhibitor with other modality like TACE. And here is the upcoming ongoing clinical trials, cabozantinib plus atezo, lenvatinib plus pembro, nivo plus ipi. All these are first-line treatment and having a very promising results. Few points about the immune-related adverse effect. A lot of immune-related adverse effects all over the body. However, it's not very uncommon. The rationale of treatment is if it is early, so we may ameliorate and close monitor the checkpoint inhibitor. However, if it is grade 2 toxicity, we may withhold the immune checkpoint inhibitor and giving steroids and wait and see. If grade 3 toxicity or there is a pneumonitis from the start or myocarditis, we have permanently discontinue the immune checkpoint inhibitor. Again, what about the updated guidelines now? The advanced stage, the first-line treatment now for the advanced stage is atezolizumab, first-line treatment, trimi and durva, according to the Himalaya, became again another first-line treatment, and still the sorafenib is first-line treatment. Why? Because there is a significant proportion of patients with advanced HCC may not be appropriate candidate for either the immune checkpoint inhibitor. It is not affordable, it might have some side effects. So still the multikinase inhibitor in the form of sorafenib and or lenvatinib are still first-line treatment. And in the future, again, as I've mentioned, that the systemic therapy may be introduced in the early stage according to the upcoming ongoing clinical trials as an adjuvant. We may, in the early stage, we may give one of the immune checkpoint inhibitor, combined immune checkpoint inhibitor, after leukoregional, after surgery, as an adjuvant to decrease the recurrence rate after 5 years. As you know, in the early stage, after leukoregional or surgery, the recurrence rate, 5 years recurrence rate, is up to 70–75%. So if we give adjuvant therapy in the form of immune checkpoint inhibitor after cure, we may reduce the incidence of recurrence. Again, in the intermediate stage, with TACE, we may give systemic therapy with TACE to enhance the overall survival, or replacing TACE according to the upcoming ongoing clinical trial that might replace TACE in the near future. And the advanced stage, we're having a lot of ongoing immune checkpoint inhibitor combination that might be very soon in the first-line treatment in the advanced stage, like NIVO and IPI. And thank you very much.
Thanks a lot, Professor Ashraf, for this elegant talk. Now we have 5 or 10 minutes for discussion.
I think, Chair, we can start by each lecture. So if there's any questions for the lecture of Professor Imam Waked and Dr. Mohammed Abdullah. Dr. Mohammed, I would like to ask, according to your review of data, what about the compliance of patients coming for screening and surveillance for hepatocellular carcinoma? Verifying the data, do you have a difference between their first visit and the next visits? That's a point. And second point, did you find a difference in the timing of diagnosis of HCC? Either it was early in follow-up or it was later?
Of course, we faced in the beginning some declining in the rate of compliance in follow-up visits, especially in COVID-19. But now we have a highest rate. We can come back again with the highest rates of compliance for visits. As for our findings or notification regarding the changes in the pattern of HCC or the detection of focal lesions, of course, in the beginning, in the first wave, we faced huge masses, 5 to 6 centimeters and something like that. But now we are facing very small focal lesions, and that increase the rate of treatment success.
Patients presenting now are in early BCLC stages?
Yes. I think all of them in the early stages, and this makes the possibility of cure higher.
Do you have a certain plan to increase compliance of patients again for the follow-up visits? Because as I think the majority of them thinking that they have ended the treatment for hepatitis C virus, so they will decline the number of visits.
Our plan in linkage to care rely on different options, either by phone calls, using treatment centers to call patients, either through social media and media campaigns. And we are planning to launch a large media campaign for make a focus on the importance of follow-up for cirrhotic patients. As you know, dear professor, most of patients, when they got an SVR after treatment of HCV, he thought he didn't need to be follow-up anymore, and he's got rid of virus, and so there is no need for follow-up. But now we are focused. It's important to follow up your condition, especially you are a cirrhotic patient, even after achieving an SVR.
Okay. Any personal question for Dr. Mohammed Abdullah? Okay. Yeah, for Dr. Mohammed. Next question. Okay.
Thank you.
Professor Gamal, are you with us? Professor Gamal Asmat? مش معنا? Okay.
Okay. Professor Peter, are you with us?
I am with you. Salam alaikum.
Salam wa rahmatullah. Okay. Regarding the risk of HCC in NAFL, as you know, many people has NAFL everywhere, all over the world. Who you prefer to screen for risk of HCC, and what is the protective role of statins, beta blockers, and coffee in prevention of HCC in NAFL?
So we have this recommendation that if you have information on the fibrosis stage, F3 and F4 would be a good justification for surveillance. This is not available for everybody, and sometimes FibroScan can be complex in the setting of a heavily obese patient. But I believe that if you are an experienced hepatologist and you see spleen size, platelets, the aminotransferase ratio, comorbidities such as diabetes, sex, male is worse than female apparently, age, and alpha-fetoprotein level. So if you take all these clinical parameters into account, I think experienced hepatologist has no difficulties to separate those at high risk versus those at low risk. This is probably more complex if you go into a general population setting. There it is less clear whom to screen and whom not, and the numbers are very high. Concerning the chemopreventive action of certain forms of treatments, statins are described, at least in some cohorts, to be effective in terms of an anti-inflammatory and a tumor preventive impact. If they are justified by the lipid level, it's certainly a good way. Metformin has been described to have a certain impact on reduced cancer development, and coffee is recommended in these days by most modern guidelines, as it is antifibrotic and protecting against HCC. More than 4 cups are recommended.
Okay, thanks, Professor Peter. Any questions for Professor Peter? Okay.
Dr. Peter, how are you? This is Ashraf Omar. You are so much welcome.
Good to see you, Ashraf. I'm well, and I hope you're well as well.
Question is about the low response rate of immune checkpoint with patients with NAFLD, HCC, or a kind of resistance to the immune checkpoint inhibitor. Which is much more important, much more accurate, resistance or a kind of less response?
I would go one step back, Ashraf, and ask the question, are we already convinced that immunotherapy is not working in fatty liver-driven HCC? I'm not convinced. I have to say we have conflicting data, and they are all coming from post-hoc analysis. And in, for example, the Himalaya trial, the subgroup of patients with NAFLD actually were responding well. And interestingly, hepatitis C-driven hepatocellular carcinoma was not responding well in the Himalaya trial. So I think there are conflicting data, and the observations in mouse models are intriguing and very interesting in terms of the contribution of CD8 cells. But it is absolutely unclear presently, and we need to do prospective trials where we stratify for etiology and really find out whether there is a poorer response. And then the question you were asking, whether it's resistance, existing resistance, developing resistance, or what is contributing to a possible difference in the outcome. But for me, I currently would not accept that navel-driven HCC is responding less well. There are signals which need to be further evaluated.
Any question for Professor Peter? Okay, thanks, Professor Peter. Now we shift to Professor Ashraf Omar. Any question for Professor Ashraf?
Thanks, Professor Ashraf, for your elegant talk and keeping us updated regarding systemic therapy. In the past, it was not recommended to give adjuvant therapy after ablation or resection. And you mentioned the ongoing trials to combine immune checkpoint inhibitors, either monotherapy or combined therapy, with molecular targeted therapy, or either with local regional therapy. Do you think this will change the landscape future of HCC management? Especially you said maybe the systemic therapy, the standard care. Thank you, Professor Ashraf.
Thank you for this important question. One of the unmet needs in the management of hepatocellular carcinoma is to decrease the recurrence rate in the very early stage. After leukoregional treatment, after surgery, we may face recurrence rate up to 75% in 5 years. So this is one of the unmet needs. In the past, the adjuvant therapy with sorafenib didn't show significant overall survival or significant reduction in the recurrence rate after leukoregional or surgery. So there is an initial good results with the immune checkpoint inhibitor. This is what we are going to see after the clinical trial, the ongoing clinical trial with the immune checkpoint inhibitor as an adjuvant in the early stage. It might, of course, changing the landscape of the treatment in the early stage. And again in the intermediate as well. The intermediate stage is now a lot of ongoing clinical trials that might combine TACE or replacing TACE in the intermediate stage. That might again will change the landscape of the treatment. Adjuvant, it has a certain protocol. Maybe Dr. Imam Waked is having the ongoing clinical trial now in Egypt that might say the exact duration of the adjuvant. 3 years and follow up to see the recurrence rate. Okay. It's a matter of cost. يعني هي المشكلة في الكوست بس مش أي حاجة تانية.
Well, there is a large clinical trial ongoing in Egypt and in other countries on using adjuvant immune therapy after curative treatment, after resection and radiofrequency ablation. It's ongoing, and we will know the results after 2 years. But it's a large trial, and we have it ongoing in the National Liver Institute and in 4 other centers in Egypt.
Thank you, Professor Ashraf. Next, I'd like to introduce Professor Iman Ruisha for the Bayer Symposium.
بسم الله الرحمن الرحيم. كل سنة وانتم طيبين. Hepatology on Nile 8. I would like to thank Professor نبيل. أنا سعيدة جدا إن Hepatology on the Nile رجع تاني بعد توقف 2 سنين عشان الكوفيد. وسعيدة لوجودي معكم. أنا هتكلم على السورافينيب والروجرافينيب في treatment of hepatocellular carcinoma. طبعا احنا عارفين hepatocellular carcinoma is the fifth most common cancer all over the world, وهي second leading cause of death among all cancer related mortality. المشكلة عندي في الهيباتوسيلر كارسينوما ان انا عندي ايونيك تيومر. ايونيك تيومر ليه؟ لانه ما بيجيش على هيلثي اورجان، ده بيجي على ديزيزد او سيروتيك اورجان. برضو المشكلة ان انا discovered the disease late بعد ما يكون عدى الستيج بتاع الكيوراتيف ثيرابي. الجابانيز هم بس اللي قدروا يدسكفر الهيباتوسيلر كارسينوما at an early stage البي سي ال سي 0 او A اللي هو الامنبل لكيوراتيف ثيرابي بيدسكفر at least 60% of their HCC cases during BCLC 0 or A، وعشان كده ممكن you can offer liver transplantation resection or ablative therapy ويبقى فيه complete cure. للأسف معظم الكونتريز including Egypt بدiscovered late وممكن ما يبقاش فيه curative therapy ونبقى بدأنا ندخل في البالياتيف ثيرابي. according للBCLC 2022 معظم البيشنت هيدسكفرد في الستيج بتاع BCLC ستيج B. البي سي ال سي ستيج بي ان انا عديت الكرايتيريا بتاعت الميلان وبقى عندي مالتيبل فوكال ليجن بس ستيل اي هاف بيرفورمانس ستاتس 0، ستيل اي هاف نو فاسكولار انفيجن، ستيل اي هاف نو اكسترا هيباتيك سبريد. according للبي سي ال سي 2022 انا عندي 3 حاجات ممكن اعملها. if I can do liver transplantation بس with extended criteria for liver transplantation يعني beyond the Milan criteria, this will and good. I will proceed to extended criteria for liver transplantation, but I must put into consideration that the overall survival will be less than those patients which I detect them inside the Milan criteria, and I must put also in mind that hepatocellular carcinoma recurrence after liver transplantation will be more and more in those patients which will be operated under extended Milan criteria. If I can't did liver transplantation with this extended criteria, so I must proceed to TACE. هو احنا هنقول دلوقتي او انا هقول دلوقتي وهنجمعها، سواء انا هقول الترانس ارتيريال امبولايزيشن او ترانس ارتيريال كيمو امبولايزيشن الكونفنشنال او الدراج اليوتد بيد ترانس ارتيريال كيمو امبولايزيشن، احنا هنطلق عليهم كولكتيفلي كده التيس علشان يبقى الكلام كوانسايزد. هو في فرق طبعا بالترانس ارتيريال امبولايزيشن ان انا جاست بعمل امبولايزيشن للفيدنج ارتي بوليفينايل الكحول. ترانس ارتيريال كيمو امبولايزيشن الكونفنشنال انا بحط دوكسيروبروسين او ايبيروبروسين على ليبيدول ايمالشن، وبعد كده بعمل امبولايزيشن برضه بالبوليفينايل الكحول. بعد كده الدراج اليوتد بيدز عملوها علشان السلو ريليز بتاع الكيموثيرابي ما يبقاش فيه هاي سايد افكت من الكيموثيرابيوتيك دراج، بلس ان هي بروتكت السيروتيك ليفر اللي هو بره الاتش سي سي، فيبقى الانسيدنس بتاع الليفر ديسفانكشن بعد التيس يبقى اقل شويه، بس الاوفر اول سرفايفل بتاع الثلاثه وجدوه ذا سيم. فانا لو البيشنت ما نفعش معايا بالاكستندد ميلان كرايتيريا انا المفروض هبروسيد للتيس. نفرض ان انا عندي البيشنت في نفس البي سي ال سي بي، يعني ما فيش فاسكولار انفيجن، ما فيش اكسترا هيباتيك سبريد، بريفورمانس ستيت برضو 0، بس المشكله ان انا عندي انفلتريتيف تيومر، ما عنديش ويل كولايزد تيومر، ففي الوقت ده التيس مش هينفعني واي ماست بروسيد تو السيستميك ثيرابي. طيب نيجي للتيس اللي هو يعني معظم عيانينا هيبروسيد للتيس. التيس ده بقى انا المفروض ابريدكت البروجنوزس بتاع التيس هيحصل له ايه، المفروض ابريدكت مين اللي هعمل له ري تريتمنت فور تيس، وانا هعمل التيس فور هاو لونج، يعني انا هتنيني اعمل تيس فور ايفر هو فينت ولا انفينيت ثيرابي. هل في حاجه تقول لي التيس بعد كده هيستجيب او ما يستجيبش؟ هم حاولوا يعملوا سكورز علشان تو بريدكت مين هيستجيب من مين مش هيستجيب، من I better refer to systemic therapy from the first، مين I will better to go to transarterial chemoembolization first. فاتعمل الهيباتيك ارتيريال امبولايزيشن بريجنوستيك سكور اللي هم سموه الهاب سكور علشان يقول لي مين هيستفيد اكتر من التيس ومين من الاول I will prefer to date systemic therapy. الهاب سكور ده عباره عن 2 ليفر فانكشن و2 تيومر كاركترستكس. ده الهاب سكور قسموه لهاب A B C و D، وعباره عن البومين وبيليروبين والالفا فيتو بروتين فوق 400 او اقل من 400، والسايز اوف ذا تيومر above 7 سنتيمتر اور below 7 سنتيمتر. وهم قبل ما يحطوا الكرايتيريا بتاع 7 سنتيمتر هم عملوا التيومر سايز من 3 to 5، من 5 to 7 واباف 7. زي نوتد ذات من 3 till 7 من 3 till 7 the same response and same overall survival. بعد 7 بيتغير الاوفر survival زي ما طبعا احنا عارفين مع البيج سايز او اللارج سايز اوف ذا تيومر بيبقى عندي الفاسكولار انفيجن وبقى عندي الساتلايت الموجود. فقسموا الهاب سكور ولقوا ان انا لو عندي هاب A او B فانا بيتر ان انا اعمل ترانس ارتيريال كيمو امبولايزيشن، والاوفر سرفايفل في الهاب A بتوصل لحد 27 مانثس، الاوفر اول سرفايفل في الهاب B بتوصل لحد 18 مانثس. نيجي بقى على الهاب C هيجي لي 9 مانثس، والهاب D هتبقى about 4 مانثس. فعشان كده طلعوا فاينل كونكلوجن ان انا لو لقيت البيشنت هاب B اور هاب C it is better ان انا اجو تو systemic therapy or post supportive care على طول من غير ما ادخل في التيس. عملوا كومباريزون بين الهاب وبين اذر سكورز. الاذر سكورز زي التشايلد سكور، زي الميلد سكور، زي الاوكودا، زي الكليب، زي البي سي ال سي، ولقوا ان الهاب سكور مور كونكلوسيف في البروجنوزيس والاوفر اول سرفايفل بتاع البيشنت عن كل السكورز اللي موجوده دي ما عدا الكليب سكور في السكند يير اوف لايف. طيب انا هتنيني اعمل تيس فور ايفر ولا في حاجه تقول لي جاست ستوب ما تعمليش تيس؟ في برضه سكور عملوه اللي هي assessment of retreatment of TACE وسموه الارت سكور. الارت سكور انا بقيس special parameters pre to TACE 1 and then I repeat the same parameters pre to TACE 2 واشوف البارامترز دي عم حصل لها ايه وتشينجز في البارامتر واقدر احسب سكور اشوف انا هقدر هيستفيد من السكند تيس او better to stop before I will do the second test. الارت سكور بس هم حطوا كرايتيريا ان المفروض ان بين الفيرست تيست والسكند تيست ما يزيدش عن 90 دايز. الارت سكور حطوا له البوينتس الابسنس اوف راديولوجيكال تيومر ريسبونس وابسنس اوف راديولوجيكال تيومر ريسبونس according to EASL means that I must did 50% necrosis of the tumor. So if I will accomplish this and 50% of the tumor will go into the stage of necrosis, it will take 0. If less than 50%, it will take 1 point. AST elevation more than 25% from the first test to the second test take 4 points, and child bow increase. If the child bow increase only one point, it will take 1.5 point. If the child bow increase 2 points or more, it will take 3 points. And the sum of these points will indicate to me whether I will repeat the test or not. And they go to final conclusion. If the sum of this point from 1 to 1.5 point, so I will proceed to the second test and it will be a good prognosis and good overall survival. But if the point is above 2.5, better not to proceed to the second test and I will proceed to systemic therapy or post supportive care from the start. في ستاديز كتيره قوي جت تشوف التيس، هل التيس انا بعمله على كرايتيريا كل الناس بتلتزم بالكرايتيريا بتاع التيس اللي هي ما فيش فاسكولار انفيجن اللي هو بي سي ال سي بي ما دخلتش في السي اللي هو تشايلد ايه ولا لا. فاتعملت الاستادي الكبيره دهيت على 1650 بيشنت، لقوا ان about 39% من الناس اللي داخلين تيست اوريدي دول من الاول تيست انيليجيبل، وبعد ما بعمل الفيرست تيست بيطلع لي about تلتهم يبقى تيست انيليجيبل. العمل الاستادي اتعمل فيها التيست 4 تايم تيستس، وشافوا الراديولوجيكال ريسبونس في افري وان، في تيست نمبر 1 تيست نمبر 2 تيست نمبر 3 تيست نمبر 4. لقوا ان الريسبونس بيقل كل تيست، يعني لو انا جبت كومبليت راديولوجيكال ريسبونس في تيست 1 هيبقى اكتر من الكومبليت راديولوجيكال ريسبونس في تيست 2، اكتر من الكومبليت راديولوجيكال ريسبونس في تيست 3. وشافوا السايد افكت وقسموا السايد افكت الاكيوت سايد افكت اند كرونيك سايد افكت. اكيوت سايد افكت within the early 30 days وكرونيك سايد افكت beyond the first month till 90 days. ولقوا ان في acute side effect according للليفر فانكشن موجوده في التيست سواء في acute او في كرونيك، والسايد افكت موجوده سواء هو كان عندي تيست eligible او تيست ineligible، بيحصل كرونيك واكيوت سايد افكت. اللي طلعوا من الاستادي دي ان انا هل انا لو البيشنت بتاعي بقى تيست ريفراكتوري and then I start sorafenib early ولا I didn't start sorafenib except after a period of time. ولقوا ان انا if I start sorafenib early يبقى it is better to me والاوفر survival بتاع الستارت اوف sorafenib early after failure or refractoriness للتيست بقى about 16 months. But if I defer sorafenib therapy for a while overall survival بيبقى 12 months. طبعا دكتور اشرف يعني ريحني كتير. طبعا سورافينيب مالتي كاينيز انهبيتور وهو الفيرست دراج ابروفد، هو ابروفد في الرينال سيل كارسينوما، ابروفد في الثايرويد كانسر، ولاستلي ابروفد في الهيباتوسيلر كارسينوما. الدوز بتاعته المفروض ان انا الدوز بتاعته المفروض ان انا هدي 800 مللي جرام ديلي 400 و400 but I may escalate the dose according to the presence of side effect. ممكن ادي لحد 400 مللي جرام. ولقوا برضو عملوا ستاديز ان انا لو عملت اسكيليشن للدوز ان انا لو قللت الدوزج I will get a better overall survivor than I will stop the drug at all. طبعا هو better to be taken on an empty stomach علشان الفود كونتنت الهاي فات كونتنت في الفود. لو انا عندي هاي فات كونتنت اوفر 50% بينترفير مع البايو افيلابيلتي والابزوربشن، فبتر ان انا اديه على ايميتي ستومك او اتليست نون فاتي فود. ملوش اي دوز ادجستمنت في الهيباتيك امبيرمنت تشايلد A وتشايلد B. ملوش اي ادجستمنت في الرينال امبيرمنت، بس هما ما اختبروهوش في البيشنت ويز هيمودايلس. طبعا هو كونتر انديكيتد ديورنج بريجنانسي لانه له تراتوجينيك افكت. السايد افكت رير، يعني الموست كومن سايد افكت اللي احنا ممكن نشوفها الدياريا، الانوركسيا، الفاتيج، الهايبرتنشن نوت مور كومن علشان انا عندي السيروتيك بيشنت داخل دايما في بريفرال ارتيريال فازو دايلاتيشن فهو اوريدي بيبقى هايبوتنسيف، فعشان كده الهايبرتنسيف كومبليكيشن انا مش بشوفها كتير في حالات اللي بس سيلر كارسينوما زي ما اكون بستعمل السورافينيب ثيرابي في الرينال سيل كارسينوما او في الثايرويد كانسر. نيجي للهاند اند فوت سندروم برضو زي ما دكتور اشرف قال. الهاند اند فوت سندروم in spite it is a toxic complication from the drug, it has a prognostic indication that the patient will respond and the patient will have overall survival more the patient who didn't develop hand and foot syndrome. What is the cause? They didn't know, but it's many explanation. It may be because the drug has anti-angiogenic effect. It exerts the same anti-angiogenic effect on the skin, which has a high replicative manner. Maybe the anti-angiogenic effect of the drug induce hypoxia, and this maybe this hypoxia go to pro-inflammatory cytokines and did immune mechanism. الحاجه اللي الدكتور اشرف عليها ان انا هستيل السورافينيب ان سبايت ان في اتيزوبيفا، ان عملوا الجيديون ستادي لقت ان انا ممكن ايوز السورافينيب في تشايلد بي سيروزس مش جاست تشايلد ايه، بت اي ماست بي كوشس لان السايد افكت في تشايلد بي 8 و9 هتبقى more and more، انما I can use sorafenib in child B7. I must modify the dose better than I stop the drug، والoverall survival بتبقى أحسن. السكند لاين ثيرابي if I have sorafenib failure or progression of the disease on sorafenib. الرجورافينيب برضو مالتي كاينيز انهبيتور، واثبت ان هو بيزود الاوفر سرفايفل، يعني لما ادوا رجورافينيب فيرسس انهم ادوا بلاسيبو الاوفر سرفايفل زاد من 10 مانثs ل 2.2 مانثs، ولقوا ان السايد افكت بتاع الرجورافينيب از ا تولربل سايد افكت، والرجورافينيب is a good second line therapy after progression of the patient or after there's a toxic effect, but I must give regorafenib therapy in a patient tolerable to sorafenib therapy. At least he tolerate more than 400 milligram per day for 21 days in the last 28 days. Lastly, sorafenib therapy can be used if there is a recurrence of hepatocellular carcinoma after liver transplantation, and it increases overall survival with the same side effect, no more increase in side effect if the patient doing liver transplantation or not. And finally, thank you.
Thanks, Professor Iman Rouisha, for this elegant presentation. Now we'll finish the first session and move to the second session.
كده ولا شغال؟ دكتور محمد هنبدأ اللي هو ال HCC. تمام، وزي ما احنا هو بلغ لي واحد هيجي يقول له حضرته هيتدخل له ورايا في الوقت اللي بقول لك عليه. تمام، افتحها اديني بوينتر بس في ايدي. لسه السيشن هيبدأ. بس يلا بقى عشان الوقت. اقلب من يمين وشمال. هنا يمين وشمال في تحت يعني. خلاص؟ تمام. And Professor سامح عبد الوهاب.